Hello, I'm Michael Todd. I am a trauma and critical care surgeon associated with the Havasu Regional Trauma Center, and we're going to talk about spine and spinal cord trauma today. So spine injury must always be considered in patients who receive multiple injuries. Some patients with spine injury experience new or worsening symptoms after treatment in the emergency department, which can be caused by inadequate mobilization. So, of course, one of the requirements of these patients is that they receive adequate spine immobilization. We do that in patients in whom we suspect a spine injury. So when do you suspect a spine injury? Well, those injuries are suspected based on mechanism. This patient, for example, is likely to have a number of traumatic injuries. Any patient who complains of spine pain or tenderness after such an event should be considered to have a spine injury until proven otherwise. Certainly, we're concerned about patients who are already manifesting neurologic deficit that's attributable to a spine injury. And we have to be very careful of patients who are unconscious, who cannot tell us whether or not they have spine pain or tenderness. So how does one protect the spine during these during the transport and evaluation of these patients? Well, you immobilize the entire spine by placing the patient on a long board with proper padding and applying a semi-rigid cervical collar. The goal in these circumstances is not to detect the injury, but to protect against a possible injury. Detection is better done at a definitive trauma center by radiologic and examination. Screening occurs appropriately in patients who have a normal neurologic exam and the absence of spinal pain or tenderness. Be careful of patients whose responses to painful stimuli may be masked or blunted because of intoxication with drugs, alcohol, or other distracting injuries. So spinal injury screening occurs on a physical exam basis if the patient is cooperative and conscious and able to concentrate and not be distracted by other concomitant injuries. If the patient has no neck pain, no spine pain, or spine tenderness on examination, and still has no pain with voluntary movement of these joints, then these patients can be cleared by physical examination alone. Outside of the maintenance of all of these characteristics, further radiologic evaluation is indicated. Radiographic visualization of the entire spine should be performed in these patients. This can also be augmented by plain films or by CT scan. The reason we protect and further evaluate the entire spine is that in as few as 10% of patients who have a C-spine fracture have a second concomitant non-contiguous vertebral column fracture in some other position. So the rule is that if you identify one abnormality, you must look for another and clear the entire spine. Again, spinal evaluation can be complicated by altered sensorium, as occurs in patients who are intoxicated or otherwise injured. It's important to remove the spine board in patients who have been evaluated by log rolling the patient. This allows decreased risk of developing pressure sores. So how do we assess the patient's neurologic status? Well, we can describe it by neurologic level as manifested by the level of loss of motor or sensory function. It's important to note that the level of these functions may be different, especially if the injury is not complete, and it may vary from side to side depending on the microanatomy of the injury. We can also assess and describe neurologic status of spinal injuries, not on the neurologic level, but on the bony level of the column injury. Incomplete injury is often associated with complete loss of somatosensory and motor function below a particular level. But incomplete injury may be manifested in which there is preservation of some somatosensory or motor condition below a particular injury. An example of this occurs with sacral sparing, seen in some patients who are otherwise paralyzed as a result of spinal injury. So what are the indirect effects of spinal cord injury? One common effect is the development of neurogenic shock. This is not to be confused with the most common cause of shock in trauma patients, that of ongoing traumatic blood loss, but this phenomena is due to a effect of loss of sympathetic tone. It's almost always associated with cervical or high thoracic spine injuries, as lower injuries often do not result in the massive changes in sympathetic tone required to manifest the cardiovascular phenomenon which is observed. The effects are often hypotension and bradycardia, and is treated first with fluid resuscitation, and sometimes with atropine and intravenous vasopressors. Other consequences of spinal cord injury can involve inadequate ventilation. The third, fourth, and fifth cervical levels provide input to the motor nerves carried by the phrenic nerves to the diaphragm. Primary or secondary injury at these levels can worsen ventilatory function and require ventilatory augmentation by endotracheal intubation. Other concerns regarding spinal cord injury result from the patient's inability to manifest painful stimuli as a result of abdominal wall anesthesia. And similar efforts can occur in patients who have extremity injury, as they may develop an occult compartment syndrome because of their inability to perceive a pain in the limb. So how do we treat spinal cord injured patients and limit their secondary injury? We do it the same way that we limit secondary injury in the cranial cavity. We ensure adequate ventilation and oxygenation, avoiding hypoxemia. We allow appropriate blood pressure to maintain adequate perfusion of the spinal cord, thus avoiding hypotension. In patients who are hypotense, we are always concerned about associated ongoing bleeding in trauma patients. We consider neurogenic shock, and we monitor their urinary output to ensure adequate resuscitation and renal perfusion. Don't forget to stop the bleeding. Again, I emphasize this point because the most common cause of hypotension in the trauma patient, even spinal injured trauma patients, is ongoing vascular loss. We transfer patients who sustain neurologic deficits and have unstable fractures. We do not delay for unnecessary testing. Management of those patients requiring transfer, again, requires that we exclude other life-threatening injuries, and that we avoid improper immobilization and hypothermia. Some of these patients require endotracheal endotracheal intubation to support their respiratory function before transfer. So in summary, the spinal column consists of the bones that protect the spinal cord, and that the neurogenic shock is associated with some cervical and high thoracic injuries. Spine injury with or without neurologic effects must always be considered in patients with multiple injuries. We protect the entire spine because of the likelihood of multiple spinal injuries. And we transfer those patients with vertebral fractures and spinal cord injuries to definitive neurosurgical care facilities. This is the 2D imaging of a patient who sustained temporary loss of consciousness and profound paraplegia after a fall from a long distance. The C1 vertebral arch here is fractured as designated by the white arrow. Remember the rule that the finding of one cervical spine injury suggests the presence of another one, and indeed further two-dimensional imaging at a lower level suggests a massive injury to the body of C5 and encroachment on the canal by posterior elements. Further images further down also demonstrate incorporation of bony fragments within the spinal canal. And a lateral reconstructive image demonstrates an obvious disruption of the spinal canal at the level of C5.